Hello, everyone. Welcome to the workshop, Strive to Thrive, Understanding Your Health After a Transplant Using Your Own Cells. My name is Tom Stewart, and I will be your moderator for this workshop. Before we begin, I'd like to thank Sanofi, whose support helped make this workshop possible. It's my pleasure to introduce today's speaker, Dr. Jonathan Lambird. Dr. Lambird is an assistant professor of hematology and oncology at Wake Forest University School of Medicine in North Carolina. He has a special interest in blood and marrow transplantation, chemotherapy, and cellular therapies for patients with multiple myeloma and other blood cancers, such as acute leukemias and myelodysplastic syndrome. Please join me in welcoming Dr. Lambird.
Well, thank you for that kind introduction, and I'm looking forward to talking to you guys about thriving after completion of your autologous stem cell transplant or transplant using your own stem cells. So we'll go ahead and get started. Today's learning objectives are to review the late and long-term complications that may develop after an autologous stem cell transplant. We'll discuss the risk factors for developing each complication, and we'll outline strategies to identify and address symptoms that may be encountered after an autologous stem cell transplant. My goal for this talk is to help individuals who have undergone this procedure and their loved ones to know what to expect after completing this intensive form of chemotherapy. So as a way of introducing the talk, I wanted to go through a little bit about and just review what things have already I assume have already occurred. So most patients who go through an autologous stem cell transplant have a form of cancer, most often a blood cancer like lymphoma or multiple myeloma. Sometimes patients with germ cell tumors, also referred to as testicular cancers, may also go through with this procedure. It includes taking out stem cells from the person who will receive the chemotherapy, and then administration of a very high dose of chemotherapy that's toxic to the cancer, but it's also toxic to those blood-forming cells. What we do after the chemotherapy has been administered is we re-give those stem cells that were taken out beforehand back as a form of a rescue so that the blood-forming cells can regrow after the chemotherapy has done its job treating the cancer. As I looked through the topics that will be discussed as part of this whole conference over the next week, I realized that there used to be two forms of stem cell transplant that we would talk about, and now there's actually a third, that CAR-T therapy. So because this is an early talk in this conference, I wanted to provide a little bit of an overview so that you had an idea of what people are talking about when they mention a specific form of transplant. So I've got three columns here labeled HSCT, ASCT, and CAR-T. So HSCT, it's a mouthful, so I had to abbreviate it, hematopoietic stem cell transplant. And this is when someone gets a stem cell transplant from someone who is not themselves, from a donor, a relative, or somebody that they may not even have ever met. An autologous stem cell transplant, ASCT, is the transplantation from cells, and that's what we'll be talking about today. And then CAR-T is a relatively new form of therapy that also involves giving not stem cells, but mature immune cells from the individual back to him or herself after a dose of chemotherapy. Now, the chemotherapy dose that's used for autologous and an allogeneic HSCT and ASCT is very intensive. The CAR-T therapy, chemotherapy, tends to be less intensive. The source of the benefit with an allogeneic or HSCT is really the infused cells. The goal is to initiate an immune response to the cancer. With ASCT, what we'll be talking about today, really the benefit for cancer treatment is primarily in the chemotherapy, not so much in the cells that we give back. And with CAR-T, it's actually going back. It's the infused cells that do the heavy lifting to treat the cancer. The late effects can be quite variable as well. An allogeneic stem cell transplant, there are many side effects that can be related to the chemotherapy, which can be very intensive, and to the immune system side effects. In an autologous or stem cell transplant from oneself, the side effects really are related to the chemotherapy dose. And then in CAR-T therapy, there are fewer chemotherapy-related side effects, but there can be some very unique long-term side effects, and that'll actually be a topic for discussion at a later talk in this conference. So Again, I wanted to introduce what you may have already gone through, which after transplantation, there is a decline in quality of life. So this is a talk that's specifically, or a graph that's taken from patients who have undergone or may not have undergone transplantation for multiple myeloma. And what you can see if you follow this red line with your eyes is around the time that patients get their stem cell transplant, there's a decline, that's that low point in the red line, in reported quality of life, things like energy and activity. However, with time, there is recovery, and the quality of life reports, or self-reported quality of life, does return to its baseline value, or maybe even a little bit better. And so that's the important part. We're going to help people kind of dig out of that hole and make sure that you know how to really live a great life after you've completed the transplantation. So what are those early side effects? And when I think early, I tend to think in the first 6 months. So we want to think about things like low blood counts, maybe requiring a blood transfusion. There's also a risk of infections, and your doctor may have or have had you on a number of antibiotic therapies to prevent certain infections. Many patients experience fatigue or reduced strength and activity level. Many patients also note that they have reduced taste and may not eat as much as they used to after before their transplantation. And as I illustrated with that graph in the last slide, there can be a reduced quality of life. So what are the things that your doctor is going to be doing, especially early after transplantation and even for the time after, regarding that initial disease that led to the transplantation? So for multiple myeloma, patients routinely go back on what we call maintenance chemotherapy. That's typically drugs like Revlimid or daratumumab. It may be tailored specifically to your case, and so it's a good thing to ask if it's not already been discussed with your transplanting doctor. Patients with lymphoma may or may not go on to maintenance chemotherapy after transplantation. When maintenance is used, it's usually drugs like rituximab or brentuximab. However, it's not uncommon for patients with lymphoma to receive no maintenance chemotherapy after transplantation. And then the doctors who identified and treated your cancer initially are going to want to monitor you with lab work, potentially some specialized scans, and occasionally with a bone marrow biopsy to monitor for possible disease recurrence after transplantation. The specific tests that you receive may be individualized to your specific case. And I wanted to point out that there's actually going to be a talk Sunday afternoon on multiple myeloma maintenance. If you have that condition and are looking at maintenance chemotherapy, that'll be a good source to learn about duration and other drugs that can be used. So let's talk really about the meat of the topic is really late recovery, and what are things that you should expect, and what are things that you can do to overcome the possible long-term consequences of stem cell transplant. So I kind of think of things as a physical recovery, a mental recovery, and a social recovery. Usually this starts around the 6-month mark after transplantation. Many of my patients will return to work after about 6 months. And for those who weren't working, they return to previous levels of activity. We also encourage people to re-engage in physical activity if their physical strength and stamina has come back, and we recommend that it will come back better with improvement in activity. So it's kind of a circular thing. There's also a mental recovery that comes back, that comes along with getting back into things after stem cell transplantation. So engaging in things like support groups may be very beneficial, and you may still be experiencing some lingering effects of brain fog. And then there's the social recovery. We recommend at our center that patients really do reduce the number of social interactions that they have in the name of reducing the opportunities for infections and contamination with germs that they're otherwise not going to be exposed to. And so after that first 6-month mark and for some time after, we recommend a stage re-engaging in social activities, which can be sometimes really beneficial to see family members or extended family and friends that you maybe haven't seen in a while. But getting back into the swing of things after being out of it for so many months can be sometimes bittersweet. And we recognize that and try to be prepared for that on the front side. So part of the reason that we recommend reducing social interactions is because the immune system is pretty significantly reduced after the transplantation. For most patients, their white blood cell count goes to 0, and they have to undergo pretty intensive antibiotic therapy just to prevent some pretty normal or infections that a healthy immune system would otherwise not be a problem. And so it's important to realize that the different components of the immune system recover at different rates. And so at our center, we typically would keep people in the hospital or around the hospital until the neutrophil count recovery. That's one subset of white blood cells. However, there are other subsets of white blood cells and other components of the immune system that may, instead of taking 2 weeks to recover, may take 6 months or even a year. We usually recommend revaccination with what we call baby shots, and the routine shots we typically start at my center around 6 months. There are certain shots, specifically COVID and the flu, that data would support using those shots as early as 3 months after stem cell transplant. And the schedule that your vaccines are administered is transplant center specific. So here's a partial list of the vaccines that we would recommend. I'm sorry, I said partial list. This is a pretty complete list. Now, each of these shots may only appear once as a list, but it may be that the pneumococcus shot and the hepatitis B shot and others may require a series, so you may get more than one shot for each of these groupings. I want to point out that one of these shots, the MMR, over on the right column, is actually a live vaccine. At our center, we had previously been recommending 2 years from autologous stem cell transplant until administration of the MMR. Because there have been some outbreaks in the community recently, we're actually recommending our patients now take that at the 1-year mark instead of the 2-year mark. I would recommend you speak to the doctors at your transplant center to determine the best timing for that vaccine. Also, a little bit of question around its use for patients who are on maintenance chemotherapy and the benefit versus risk of administering the MMR vaccine while taking maintenance Revlimid or daratumumab or other drugs, or even rituximab and brentuximab. Those are good things to discuss with your transplant doctor. I also wanted to highlight while we're on this slide that certain vaccines that are specific to travel may be beneficial. I'll just tell a quick story. I had a patient who, after her transplantation, wanted to visit family in Africa. Now, she was pretty far out from her transplant by that point, but I was still a little bit worried about her immune system health. She was on some medicine that did reduce her immune system's functioning, and I sent her to an infectious disease specialist, and they recommended a hepatitis A vaccine, which we were able to get for her. They also recommended giving her IVIG. And while that's not probably a routine thing for domestic travel, that may be beneficial for international travel. And again, at the end of the day, the best thing that you could do is discuss with your doctor your plans and maybe potentially involve the input from a specialist. So we're going to go ahead and switch away from the immune system related recovery back to a different form of risk that does come with the autologous stem cell transplant, and that's secondary cancers. So the risk of secondary cancers is somewhat difficult to really pinpoint to a specific number, just because the types of cancers that patients have coming into an autologous stem cell transplant varies, and the types of therapy, chemotherapy, and radiation also varies quite widely. I did pull out this one study. It was a large study, and it had very long-term follow-up, so I think it does provide some context. So the study, and I've got the citation toward the end of the slide deck, found that over 15 years after the autologous stem cell transplant, about 6.7% of patients developed a new cancer. Now, to putting that into context, that's still 93% of people who didn't, but that 6.7% is still higher than in the general population. So what kind of cancers we're seeing? Well, blood cancers, or another term for this is bone marrow cancers like AML, ALL, and MDS, do occur at low rates after in patients who have received an autologous stem cell transplant. Additionally, solid tumors like lung cancer, oral cavity cancer, certain types of brain, thyroid, breast, and even skin cancers like melanoma or non-melanoma skin cancers can occur. So what are risk factors that may put one at higher risk for being someone who develops a secondary cancer? Well, going through the autologous stem cell transplant earlier after stem cell transplant, or younger at a younger age can predispose to developing a secondary cancer. Smoking is certainly a risk factor, and that's a modifiable risk factor. The total amount of chemotherapy that was used before transplantation and then after transplantation may also contribute to the risk of secondary cancers, and then also forms of radiation treatment can increase the risk. So what do we do about this increased risk of developing cancers? Well, it's very important to keep up with routine cancer screening. So undergoing cancer screening like prostate cancer screening, mammograms, pap smears, colonoscopies, engaging with a dermatologist, an appropriate specialist who can do a high-quality skin exam is important. For those who are smoking or have smoked in the past, performing lung cancer screening with chest CTs can be important. And then there may be other focus tests that have to do with your personal or family history of cancers. The frequency of testing is generally similar to the general population, but we just really encourage our patients to not miss those things or delay. It's sometimes easy to say, oh, I'll get that colonoscopy later. It's no fun to do the prep. But it's a really important thing to do, and we certainly don't want to miss the opportunity to identify and engage early with things that could, if left untreated, could be a real problem. In terms of screening for the blood cancers that I talked about on a previous slide, routine yearly blood work, like a CBC with your primary care doctor or with a transplant doctor, should be appropriate to identify abnormalities that could predispose to those types of cancers if they arise. So what are things that you can do to help reduce your risk of secondary cancers? Well, maintaining a healthy diet and regular activity is really very helpful. We would also recommend using sunscreen. It's just these little things that can be really helpful, especially for patients who are predisposed to developing skin cancers. Smoking cessation is a huge benefit to reducing risk of cancer. Your transplant doctor, your hematology oncology doctor, your primary care doctor would all be happy to discuss with you adjunctive therapies to help you quit smoking, or making use of supportive interventions like the 1-800-QUIT-NOW. And then we would recommend just keeping up with your routine health provider for routine health exams to make sure that you're on schedule for each of those cancer screenings. Also want to point out that there's a specific talk on secondary cancers. If this is something you'd like to learn more about, that'll be Monday. And then immediately following that talk, there will be another talk on protecting your skin, which will be really important for skin cancer risk reduction. So we'll go ahead and switch gears, and we'll move over to heart problems that can occur after an autologous stem cell transplant. So the risk for heart problems does increase maybe 2 to 3 times after an autologous stem cell transplant. There are many types of heart problems. They could be as common as things like high blood pressure, or it could be severe things like heart failure, cardiovascular disease, or arrhythmias. Factors that increase your risk for heart problems include certain types of chemotherapies, such as anthracyclines, which is typically it's a red chemotherapy, and you kind of know if you're getting it. Sometimes people refer to that as the red devil. Also, having certain types of treatments like radiation to the chest or smoking can predispose to heart problems after the autologous stem cell transplant. So what are things that you can do to help improve heart health after your stem cell transplantation? Well, again, engaging in regular exercise is just always a beneficial thing. Diets, specifically those that are rich in whole grains, can be very beneficial, especially at improving things like HDL, the good cholesterol. Smoking cessation is another important one. And then maintaining a healthy blood pressure is very important. And while it may seem like an easy thing to do, keeping an eye on that blood pressure with a blood pressure cuff at home or keeping up with your primary care doctor can be really important to preventing problems down the road. We would also recommend undergoing routine screening for things like cholesterol and monitoring your blood sugar, which can be done with your primary care doctor. So switching gears over to another source of problems. Now, we're going to talk a little bit about lung problems. Now, I want to highlight that lung problems tend to be very rare after an autologous stem cell transplant, and in most patients, they don't occur at all. So for patients who do experience a problem, they kind of fall into 3 categories. There's a form of lung issue called radiation pneumonitis. There are certain types of chemotherapy that can cause lung issues, and then there's a fairly rare form of toxicity called engraftment syndrome that can occur very early after stem cell transplant. So if you're 6 months or more out, these problems, if they have not arisen, probably will not. So as I was kind of listing out there last time, the chest radiation chemotherapy like bleomycin, which can be used for those germ cell or testicular tumors, and then carmustine, which is a form of conditioning chemotherapy in autologous stem cell transplant that we use for patients with lymphoma, and then smoking is a risk factor as well. So for the patients who do develop lung issues related to transplantation, the typical monitoring strategy would be lung function studies and chest CTs, and then it would probably be very important to engage with a lung health specialist like a pulmonologist. Treatment strategies tend to include steroids. Now those can be given as a pill typically, and then we would also recommend using inhaled medicines, which sometimes can be inhaled steroids. And then finally, we want to be very thoughtful about future chemotherapy use if chemotherapy was ever indicated in the future. So we'll go ahead and switch over to another form of toxicity that can occur after transplantation. That's nerve damage. So nerve damage can occur secondary to chemotherapy that was given before the autologous stem cell transplant. It can also be driven by drugs that are used during transplantation. And there may be some contributing factors like diabetes or spinal arthritis. It's important to note that certain types of neuropathy that occur or nerve issues that occur from chemotherapy can sometimes be permanent. And so if you begin to notice neuropathy, it's important to notify your doctor soon and early. I also wanted to point out that nerve damage can occur from myeloma itself, and if that's not a common problem, but it can arise. So when we talk about neuropathy, I thought it was important to define that neuropathy is essentially just any sort of sensation that's atypical that's brought on by the treatment or the disease. So most often my patients describe numbness, and that's usually from chemotherapy. There's a drug that's used in multiple myeloma called Velcade or bortezomib, and that drug often can cause, unfortunately, some neuropathy. Most patients who experience that are experiencing numbness, and typically in their feet, sometimes in their hands. Less often than neuropathy, symptoms can include symptoms of pain or cold intolerance, and if it's driven by the multiple myeloma, it can sometimes be associated with weakness. So what do we do about neuropathy or nerve problems if they arise? Well, the first thing for your treating doctor is to have a thoughtful choice of chemotherapy in the future if it's needed. We certainly don't want to make things worse. So medicinal therapy that can be used, there are drugs like gabapentin or pregabalin that many patients can find help reduce their symptoms of neuropathy, particularly the tingling and the uncomfortable part. It doesn't tend to help with the numbness quite as much. Other drugs like duloxetine, another name for this is Cymbalta, may be helpful to help people deal with their symptoms of neuropathy. And then there's non-medicinal therapy, things like physical therapy and avoiding aggravating sensations like the cold exposure or warm foot baths can sometimes be helpful to prevent bringing on those symptoms. I have had a few patients who tell me that wearing compression stockings can really help, and if they don't wear their compression stockings, their neuropathy tends to be very bad. I've also unfortunately had patients tell me that wearing compression stockings is very difficult because of the neuropathy. And then adjunctive therapies like acupuncture can be helpful for many. I'd like to point out that neuropathy is a common problem, and there's actually going to be a talk on neuropathy that will be given on Wednesday. So if you're looking for more information, that may be a great resource for you. So we'll transition over now, and we'll talk about sexual health issues that can occur after the autologous stem cell transplantation. So some patients may experience hormone issues after transplant, either due to the radiation or the chemotherapy. And that may manifest with low testosterone or low estrogen levels. It's important to note that there are alternative causes for sexual health issues after transplantation, and things like anxiety or depression are very common and may lead to sexual dysfunction in one or both partners. Additionally, things like poorly controlled diabetes can be a physical cause of reduced sexual function that can be address. So what do we do for treatment if these things arise? Well, we can monitor hormone levels and provide replacement if needed. We also want to manage those contributing diagnoses as they arise. For some patients, they may find it helpful to engage with a sex therapist or some sort of a couples counselor, depending on the cause of the sexual issues that arise. And I do want to point out again that there's going to be a talk, and this will be on Tuesday. And so if you're looking for more information on this topic, that might be a good resource for you. So let's talk a little bit about fertility issues that may arise after transplantation. So many females may find that they are menopausal after transplantation. However, if you were not menopausal before transplant, it's important to note that you may still remain fertile even if you're not having regular menses. So the absence of menses does not mean that you're infertile. If you are interested in having children after transplantation, there doesn't appear to be a risk to either the mother or the child if the mother has gone through an autologous stem cell transplant, and the same holds true for the father. So it is possible to conceive after undergoing the autologous stem cell transplant. What's important is to, especially for a mother who's gone through an autologous transplant, would be to have engagement with a very well-trained OB-GYN who is familiar with the special forms of toxicity that may be specific to pregnancy for that mother. Now, fertility issues for men are variable after transplant, and that's worth pointing out. So what do we do for fertility preservation? So ideally, on the front side, before being exposed to high-dose chemotherapy, women would undergo egg harvesting that could be stored and then used at a later time point after transplantation. So men, there are similar opportunities with sperm banking. On the backside, if you did not pursue fertility preservation on the front side, engaging with a qualified fertility specialist may be beneficial. So I want to switch over and talk about mental health challenges that can arise after transplantation. So these can manifest in various ways. So things like loss of interest in old hobbies or activities, impaired sleep, and sometimes even feelings of guilt. There's a little bit of almost survivor's guilt that can come up after you start getting back to feeling normal. You may have a friend or have made a friend who is also going through the transplantation process who maybe didn't have as good of a course. And so there are many emotions that people experience after transplantation. And I think it's important to note that those are very common. And so it's important to talk with your loved ones and even your healthcare provider if you find yourself feeling those things. So what are things that we can do if those are an issue? So I've provided a list here, things like engaging in family and community activities. I think engaging in spiritual support is very important, especially if that's something that you've engaged in prior to transplant. There are cancer support, survivor support groups that can be very beneficial, things like on Facebook or even a local survivor group that may be helpful to provide information and other stories for people who have walked the same journey that you have. Getting exercise and physical activity can be very helpful. I think it's good for the mind as much as it is good for the body. Also, practicing things like mindfulness, journaling, meditation can also be helpful. Many people find that engaging with a counselor can be helpful, and I think that there's a real role for medications to assist in managing these things. Now, I'll tell you what I tell my patients is this is a kind of a long list. There's 6 bullet points here, and really the patients who are going to do the best afterwards need to pick at least 2 or 3 from this list and make those real priorities. Engaging in any one may be helpful, but it's likely to be incomplete. So this is a multi-pronged problem, and it requires a multi-pronged solution. So we'll switch gears a little bit again, and we'll talk a little bit about cognitive health after autologous stem cell transplant. So these symptoms can be things like brain fog or difficulty remembering things or completing tasks. There are certain risk factors. Certainly age can be a predisposing risk factor. Certain medications can make you feel foggy or sleepy or just not as sharp. Certainly dietary deficiencies are things that are easy to miss. After transplantation, your appetite is altered, your ability to eat a full meal is reduced. And so it's probably more common than we realize that people actually come out a little bit B12 deficient or have some other organic endocrine problem. Also, there can be contributing features like depression or anxiety or even impaired sleep that can make it really difficult to be sharp after your transplantation. So what are things that we can do about this? Well, strategies for improvement include in some cases just the time off of chemotherapy. Your time since the high doses of chemotherapy can itself lead to some recovery. So you may not be sharp and ready right away. Additionally, there may be some formal testing for things like blood levels of vitamins or even thyroid functioning that could be helpful. Sleep apnea testing and addressing other sleep issues that may arise it can be helpful to improve your cognitive sharpness, especially if you're not feeling sharp and well rested. And then potentially formal cognitive testing, which may need to be done in a doctor's office, can be helpful. And then I would say that it's important to surround yourself with people that you can ask for help, because it may just be something that while you get back into the swing of things, you do need help remembering to do normal things. So, and I also wanted to highlight that there will be a talk on cognitive challenges after transplant that's going to be given on Friday, and also there will be a talk on the benefits and the importance of sleep after transplantation as well. So, I've hit on a number of issues that can come up, kind of specific issues that are health related after transplantation. To summarize, I want to highlight that most patients do return to their previous level of activity after transplant. I tell all my patients, my goal in taking you through this really intensive therapy is that you can get back to living a good life. And so you may be on maintenance chemotherapy afterwards, or you may not, but we want you to get back to living a good life. And part of that for right now, when we are doing the transplant, involves getting good cancer control. The best health action that you can take is really to maintain regular contact with your primary care provider and your treating hematologist or oncologist. They will be able to guide you on this journey that we've kind of gone through the number of health issues that may arise. Many of these things may never be a problem for you, but some may be a real bear, and they can help you work through these issues. Certain health issues are more common after autologous stem cell transplant, things like heart issues or even new cancers. And those can be scary, but those can also we can address those. And it's important to engage in healthy behaviors such as regular exercise and smoking cessation. Those things can have a tremendous benefit for your health and well-being. So I wanted to highlight just a few areas to get other information. So the BMT InfoNet, who is sponsoring this set of talks, is a great resource. For patients with multiple myeloma, the mmrf.org is a great resource for resources on what to expect when being treated with multiple myeloma. And similarly, the LLS.org website, the Leukemia and Lymphoma Society, can be a great resource for patients with leukemia, or lymphoma rather. So I did pull out and highlight the talks that are coming up afterwards. I'm not going to read each of these, but I encourage you guys to look at look through the upcoming talks, because they are really beneficial. Here is, if you are interested in looking, it was a paper in the New England Journal of Medicine that talked about secondary.
Our first question is, are N95 masks really enough to make air travel safe? At what point should we start flying? We can drive as long as is best.
Yeah, so that's a great question. Generally what we do at our centers, we recommend patients really try to reduce things like air travel if possible for the first 6 months after transplantation. Just the immune system, as I said, the immune system recovery is not an all-at-once process. And we also recommend use of N95 masks for the first 6 months. So use of an N95 after the first 6 months is a little bit more at the discretion of the individual. But what I would say is air travel, certainly you're on a closed airspace and you don't have a lot of control about who you're around. So if you're able to make that a car trip, it's always a good idea. And I think the second part of the question is, when is it safe to travel? That's a little bit of a loaded question. I try to have a conversation with my patient about what they're hoping to travel for. I've definitely had patients who say, I want to go on a cruise as soon as I can after transplant. I say, well, maybe try to limit your travel to maybe even more than 6 months. Maybe try to do something like that after the first year, because you will have completed more of your vaccinations and maybe will have even completed the MMR vaccine. However, there's also travel that may be less elective. So if you are needing to travel across the country to attend the funeral of a close loved one, I don't want to tell you that you can't do that if you're 6 or 7 months out from transplantation. It's not about when can I engage in these activities. The best way to think about it is how can I, in the safest manner, engage in activities that I need to re-engage in. So it's a little bit of a long answer to a relatively short question, but I think the goal should be to re-engage thoughtfully in activities, and to re-engage in a way that you're able to get the enjoyment of those activities out. So whether that's seeing family who are across the country, or whether that's engaging in fun things like finally getting back to taking a big vacation.
So how is younger age defined regarding risk of secondary cancers occurring?
Yeah, that's a fair question. So I think in general, if you were to, and I didn't have any data on this in the PowerPoint, but most patients who are proceeding with an autologous stem cell transplant for multiple myeloma are over the age of 60. The number of patients who go through with an autologous stem cell transplant with lymphoma are in general going to be younger, just because certain lymphomas can occur in young patients. But I'd say young being under the age of 40. Really, it's probably more of a continuum though. So I would say even under the age of 60. If you have probably somewhere between 40 and 60 would be the middle age. And then definitely under age 40. I think many adult doctors would consider that young for an autologous stem cell transplant.
Okay. So does what you're sharing apply to people who have had CAR T cell therapy?
So it can. So that's what I was trying to highlight in that first slide. There are many similarities, and in some cases, some patients who've gone through, who may be thinking about going to CAR T therapy, may have already had an autologous stem cell transplant. So the chemotherapy dose that's used in CAR T therapy is it's generally lower in intensity. However, the side effects are unique. So many of these side effects and symptoms may not be particularly relevant, although some may, and it would be kind of a case-by-case example. Well, you may not have the heart issues that may arise because of the intensity of the chemotherapy, but you may have different immune system issues. So I think survivorship after CAR T may be its own talk during this conference.
Okay, here's a question that was submitted ahead of time, and it's quite timely. Measles is spreading in my community. I'm not able to be revaccinated still post-transplant. Do KN95 masks work for measles? And how do we navigate this risk?
So that's a great question. So the thing I would say there is limiting your exposures is the best bet that you can take. So definitely wearing an N95 mask. So if you're too early after transplantation, definitely, trying to limit exposures to patients, to folks that you're not familiar with. So now in the post-COVID era, we kind of all have a better sense of like what a pod is like, or whatever the term that was used, where you just have a short list of people that you try to keep your exposures limited to. That is a great thing to recommend, but sometimes can be difficult to actually act on. Some of my patients, particularly those who are younger, may still have young children at home who are going to school. And so they may have a constant exposure to the community through their kids. And I've had patients who will, find another place to live for a couple months after transplantation. That can be difficult and maybe completely impossible for some people. But definitely limiting your exposure and taking the best interventions that you can take to limit your exposures, like wearing an N95 mask, are a good idea. If you're able to, kind of hunker down and try to get through it, As early as a year after transplantation, you should be able to get your MMR vaccine. And that would be what I would recommend, is really just try to limit your exposures. And unfortunately, it is a new threat that we, as a medical community, haven't had to deal with. And so we're still kind of learning the best strategies, but limiting your exposures and taking things like masking very seriously are probably your two best options.
Okay, great. So another pre-symposium question. What are the signs of a relapse of stem cell transplant?
So, relapse after transplant can take many forms. So it depends on whether you were transplanted for multiple myeloma or for lymphoma or for a germ cell tumor. And sometimes people go through with an autologous stem cell transplant for other things. Those are kind of the big three. And that's going to be specific to that disease. So relapse after myeloma is typically going to be identified on routine blood work, checking myeloma markers like your M-spike and your kappa lambda light chain ratio. Identifying relapse with a lymphoma may be identified on things like a PET scan or on routine blood work that shows changes in blood counts. Those things are typically confirmed by more intensive tests, sometimes a bone marrow biopsy if it's warranted, or a lymph node biopsy if it's a lymphoma. So it's specific to the disease that's being checked, or that was the initial cancer that led to transplant. And then beyond that, if you had a transplant for a different disease, it would be disease specific. Okay. And I'll also mention that what I tell my patients is the reason that we do maintenance therapy after multiple myeloma, transplant for multiple myeloma, is that my assumption is that it's not a curative intent therapy. It's an intervention that provides a tremendous amount of disease control and can help deepen a response and prolong a response. However, the vast majority of patients will have their myeloma come back. And so I counsel them to be ready for the relapse, and ideally it's many, many years down the road. And then we talk about strategies to deal with the relapse when it does occur.
Great. So here's a question that is only a single word question. I'm not sure exactly how to interpret it. The word is cataracts. It's not clear whether it means are cataracts a risk factor, or whether it means how do you treat them if you do have them after transplant. So maybe you could give that a shot.
Well, I sure can. So I will say that part of the treatment scheme for most lymphoma therapy involves prednisone or some other form of steroid. And a backbone, as we would call it, in myeloma therapy is to administer high doses of steroids. And so certainly over time, there's an increased risk for cataracts after long-term steroid exposure. And there's also a risk for cataracts just with things like age and other contributing factors for people who've never had chemotherapy. So certainly cataracts are something that we see in our patient population. And, typically patients who do have cataracts, once they go through with the cataract removal surgery with an eye surgeon, an ophthalmologist, benefits them tremendously. So if it does occur, it's a problem that we can address surgically fairly well and fairly effectively. And so it's a thing that we're aware of that can happen, and we just have to kind of monitor for it.
Thank you. So off on another tack now, why are heart issues, bone issues, and other cancers more common after autologous stem cell transplant?
Yeah, so it has to do with we assume that it has to do with the exposure to high doses of chemotherapy. So the chemotherapy that you receive with the transplantation tends to be very, very intensive. And the way that we explain it to ourselves and to our patients is that the cells in your body that are going to be the most resistant are going to be those that are the most capable of becoming cancer later. So they are able to survive when the other cells are not. And so there's a theory, really, not something that can be easily tested, but that we may not cause the cancer necessarily, like a bone marrow cancer, but that we sort of select for it when we give chemotherapy to treat a multiple myeloma or a lymphoma, that the cells in the bone marrow that can survive that are those that can grow to become a new bone marrow cancer like AML or MDS. Now, other cancers like lung cancer or head and neck cancer probably has a similar kind of explanation, that those cells that can survive the chemotherapy doses that we give are pretty resilient against chemotherapy. And that's where, other factors play in, though, wearing sunscreen and limiting sun exposure to reduce your risk of skin cancer, reducing smoke exposure, stopping to reduce the risk of head and neck or other cancers. And then regarding other heart issues, so the chemotherapy that we use, melphalan, can sometimes cause heart issues. It can lead to things like atrial fibrillation that can predispose to other heart conditions down the road. So it's kind of a combination of facts, but it's generally that the chemotherapy, when it goes into your body, it doesn't just go to where the cancer is. It goes to the heart, the lungs, the kidneys, the liver, the brain, and there's a potential for damage at each of those sites as well.
Okay, thank you. This patient asks, I just had my stem cell transplant in January, and I'm very concerned about secondary cancers. What are some things that I can do to reduce that potential?
So, the best thing that can be done right now would be to engage in healthy lifestyle. So I'm going to guess this patient's probably not smoking, but if you are, or if you have other things that can predispose to cancers like chewing tobacco, it would be good to stop doing those things first and foremost. The next thing to do is just to maintain a healthy lifestyle. There are some studies that would indicate that engaging in physical activity or daily stretching and other things can reduce cancer risks. Those are hard to replicate in large population-based studies, but I think that there's merit to those things. And then there are some dietary thoughts out there. Again, they're probably not supported strongly in the literature, but things like reducing things like sugar and exposure to high fructose corn syrup, those are all modifiable risk factors. It's difficult to put a number on the amount of benefit you receive from those things, but those are all healthy things anyways. They're going to make you healthier in general. And so if you're doing it in the name of general health promotion or in cancer risk reduction, they're beneficial. So outside of that, the best thing that you could do is to undergo routine cancer screenings with your primary care doctor. So colonoscopies, mammograms, pap smears, prostate cancer screening at appropriate intervals. So I think we'd have to get specific to what your specific needs are. Most people don't need a prostate cancer screening and a cervical, a pap smear. But so you would talk to your doctor about what you would need. And then, I want to highlight, like I did on that last slide, that 93% of people don't develop a secondary cancer after their transplantation. So the vast majority of people don't. But the cancer risk is slightly higher than in the general population, and so it's important to get those screenings and to engage in those activities. But do remember and take solace in the fact that the vast majority of people don't develop a secondary cancer.
Okay, thanks. Another patient asks, I'm almost 3-year post autologous stem cell transplant with a diagnosis of multiple myeloma in October of 2021. My immunoglobulin levels are still low, and since I've had a few LVIG transfusions to boost my immunity, is this really my only health challenge right now? Am I always going to be immunocompromised, or will this gradually improve? Yeah,
so if you're 3 years out, it may be that your immune system is, going to be low on immunoglobulins, and taking replacements may be a thing that's going to be the most beneficial. Something I'll say is that patients with multiple myeloma, particularly those who are on daratumumab, tend to more often be the term that I use, hypogammaglobulin-anemic, which is a big $64 word for they have low immunoglobulin levels. So for those patients, we do routinely administer IVIG, or I shouldn't say routinely, but do often do that because the autologous stem cell transplant and the post-transplant daratumumab can predispose to low immunoglobulin levels. So I would say if you're this far out, the likelihood is that it's going to persist until something changes. I don't and wouldn't routinely recommend my patients stop maintenance chemotherapy for the immunoglobulin benefit. Some patients 3 years out may be stopping daratumumab anyways in the post-transplant setting. So that's something to talk to your doctor about. I'm making that assumption. That's not a fair assumption. But it may be something that your immune system is somewhat limited from here forward.
Okay, thanks. From another patient, we have the question, 10 months post autologous stem cell transplant, still dealing with anemia. Is this common? Peripheral neuropathy of feet that started well before my multiple myeloma diagnosis is still a problem. Can this be reversed?
Yeah. So there's two questions there. So one is about the duration of anemia after transplantation. So I'll say it's really very uncommon to be in a place where you're still requiring blood transfusions after stem cell transplantation. That's actually quite unusual. Now, you can be anemic and not be requiring blood transfusions. And then we want to look at the level of anemia that's present. So a hemoglobin level that is 11 or 12 after transplantation is a little different than a hemoglobin level that is 8.5. And so I would expect most of my patients, without a good explanation, to have a hemoglobin level that's in at least an 11. And ideally, it'll get back up into the completely normal range. With that said, if it's not in the normal range, then it's fair to investigate reasons why. So checking an iron panel, a B12 level, potentially other vitamin levels, to see if there's a deficiency, especially 10 months out. Dietary deficiencies could certainly contribute. And so that would be the thing to do. Now, in some cases, patients may benefit from having a bone marrow biopsy done, but again, that would be guided primarily by the clinical picture. So the level of anemia and the potential for alternative explanations, whether those are present or absent. So, but those would be the pathway that I would take to further evaluate that issue. And I hope that that's helpful. Now, I think the second question you might have to remind me, it was like a two-part question after the anemia.
See if I can get back to it.
Sorry.
No, I'm sorry. I can't. Oh, wait a minute. No, I'm sorry. Can't find it. I think we'll have to let it slide for now. Another question, though. Is there a standard revaccination schedule?
So believe it or not, there's not a standard schedule. There's a standardized list that we use, which I provided earlier in the talk. Many of our patients at our center out in Western North Carolina live pretty far away, and they may or may not be able to get their vaccinations locally, and so they come back to us. And so our vaccine schedule is primarily built to get them vaccines at an appropriate time frame, but we also recognize that patients may be driving 2+ hours each direction, sometimes 3, just to get a set of shots. And so we try to get them as many shots as we can when they're there, just so that they don't have to make so many trips. Other centers where you may be in a geographically tighter location may use a schedule that uses fewer shots at each visit, but more visits over time. And so the transplant center that you're using does have the flexibility. For the most part, we try to be done with our vaccines by, in general, like a year and a half out from transplant. Our only shot that we give at the 2-year mark had been the MMR, and now we're trying to move that up to 1 year out for most of our patients, depending on their other health status and their potential for other chemotherapy exposures.
Okay, I did find the question from before. So the first part of the question was anemia, and is it still common? Then the second part of the question was peripheral neuropathy of feet. that started well before the multiple myeloma diagnosis, and can this be reversed?
Yeah. So unfortunately, multiple myeloma, the treatment, Velcade specifically, it's a shot in the belly, also called bortezomib, is a drug that is kind of famous for causing neuropathy. If your neuropathy was present before the multiple myeloma diagnosis, it may have been driven by the presence of the myeloma. That certainly can happen, specifically for IgM subtypes. However, I think that what you may be experiencing, at least to some extent, may be permanent, especially if it's Velcade induced. And that's where we talk about, well, what are management strategies? We may not be able to reverse it, but can we reduce the symptoms? Can we do things like gabapentin to make the pins and needles sensation less? Can we engage in some adjunctive therapies like acupuncture? And I will highlight that there is a talk later on in this conference. I believe it's on Wednesday, if my memory serves me correctly. It's on Wednesday that this will be discussed further, and you may find beneficial.
Okay. So thanks. This is going to be our last question, unfortunately, and that is what to do when your energy levels don't return to normal.
Yes, that's a great question. So first off, I would notify the doctor who's treating you. Many of my patients, not all of them, but many, do note that they have decreased energy. And I think it's important to talk about, well, decreased energy compared to when. So, for my patients who have multiple myeloma, they usually get 4 to 6, sometimes longer than 6 months of chemotherapy to get them prepped, to get them into a good place for the autologous stem cell transplant. And then they get the transplant, and then they spend 6 months to a year recovering from the transplant. And they say, "Gosh, doc, I don't feel like I had the energy that I used to have." And we'll have a discussion. Well, you were 71 when you were diagnosed. You're just about to turn 73, and so I do think that the chemotherapy that you get does age you a little bit. But so it's important to say, when was the last time you had energy that you would like to have now? And what I tell them is that I can't turn back the clock, but we can do things to try to maximize the energy that we have now. And so for patients with myeloma specifically, they're often on maintenance chemotherapy. Revlimid is the most common maintenance that we use after transplantation, with daratumumab likely a very close second nowadays. And Revlimid specifically definitely can cause some fatigue. So if that's a problem, then we talk about things that we can do. We talk about the cadence of the Revlimid exposure. Many patients would have a week off. They do 3 weeks of therapy and then a week off. That's how our center does it. Some centers do continuous dosing, which is acceptable, but it would be reasonable to try a week off and see how you feel, or maybe even a chemo holiday to see how you feel. If you really do feel better off the maintenance chemotherapy, it may not be the transplant, it may be the maintenance that's doing it to you. In which case, we sort of talk about the risks and the benefits of dose reductions, and it depends on the starting dose. If you're at Revlimid 10, sometimes we think it's going to 5. If you're on Revlimid 5 and it's really hard, sometimes we'll go 3 weeks on and then 2 weeks off. Sometimes we'll go every other week. I mean, we can kind of get creative. If it really doesn't seem to have anything to do with maintenance therapy, then we, again, identify other issues that could be contributing. Sleep, issues with mood can oftentimes cause fatigue. And also, we don't want to overlook the possibility for heart problems. If you say, "Gosh, I can't walk up 2 flights of stairs in my house anymore," well, then maybe we need to make sure the heart's still in a good condition and do an echocardiogram or something. So there are many, many ways to investigate fatigue as a symptom, and there are many things that can cause fatigue. So it's hard to have a single answer without the context of your chart. But the first thing to do is to talk it over with your transplant doctor and maybe even with your primary care provider.
Thanks, Dr. Lambird. On behalf of BMT InfoNet and our partners, I'd like to thank Dr. Lambird for a very helpful presentation. And thank you, the audience, for your excellent questions. Please contact BMT InfoNet if we can help you in any way. We hope you enjoy the rest of the symposium. Thank you and good day.